just going to start today with an apology. Any of you who saw or heard about the Nationals broadcast last Sunday may have been disappointed to see how the producer depicted Ontario universities. Of course, in my province, in Newfoundland, we take great pride in trying to make Ontario look bad, but unfortunately, and I asked the producer, so what's the angle on this story? He said, we just want to show, how great you're doing, great a job you're doing in Newfoundland. And then I said, okay, so what else? And he said, well, we went to a few universities in Ontario and we talked to students and they really weren't happy with their services. And I said, well, did you talk to the universities? No, they didn't. So I apologize. It wasn't I tried to get them to talk to U of T and Carleton, but they didn't. So they were interviewing me because they found some literature on our webpage at Memorial about the stepped care model, which we've been using for a couple of years, and a lot of interest in this. It's not a new concept, stepped care. It's been in the UK and been in primary care settings for a long time in a variety of places. But it's kind of new to North America, and what is also new is bringing in some of the technology using, this is an Ontario story, single session therapy approaches at the intake process so that you can get people in immediately. So if any of you aren't aware, Ontario has more than 50% of the single session clinics in the world, so Canada is leading in this area, and it might be something to consider in the university and college space, how the solution-focused principles that are used in single-session therapy can actually help you to get moving right away, quick access, and get some positive things happening with clients before you dig down and do deep assessment. But I'll talk about that a little bit more. So we've been working on this for a couple of years, and the more exciting thing is that people like yourselves have been consulting with us and asking us to come and train. And every time I go to a conference like this or go onto a campus, of course, I learn about the brilliant things that all of you are doing, the innovations that you're involved in. And so the model is constantly evolving. It's designed to be really flexible. The institutions that are up here are some of the universities and colleges that have adopted some form of the Memorial model. But when these programs are successful, typically there's a lot of organic adaptation that's done, and a few of the principles are kept in mind. So I'm going to go through a couple of those principles. How many of you are leaders on your sites versus staff? How many are leaders? A few of you? Okay. And how many are staff? Okay. So maybe half and half. Or others? There's maybe another category. Students? Yeah? Okay, good. So, but all of you are leading change. That's why you're here, because you're at a conference on innovation. So I find this one, we all work in the change business. A lot of people work in the change business. Salespeople work in the change business. But we work in the change business, and everybody likes change, but do you actually want to change yourself? And then secondly, do you want to lead change? And I begin with this slide because innovation is about risk-taking. And we, as a profession, we are quite risk-averse. And so part of what I'm trying to push today is encourage people to experiment a little bit, to take risks in an area where I think our risk-aversiveness collectively, although nobody's intending to be risk-averse, actually fuels stigma. Because when we're sort of afraid about suicide, when in fact suicide rates are not changing, when we put out the message that this is a horrible, horrible thing happening, even though it's with good intentions, sometimes what we lose is our sense of hope and optimism and our willingness to risk forming good relationships with people that we connect with. If our first contact is all about asking all the questions about what negative things might happen, then sometimes we need to be careful because we might be reinforcing some of that negativity. Risk assessments, the research on it, pretty poor efficacy in terms of impact of risk assessments. what's really important are conversations, and we all know that. So having conversations, having engaging conversations, conversations that stimulate resilience and optimism are important. We know in suicide prevention, protective factors are the most important thing, but quite often we're always talking about the risk. So this isn't surprising to any of you. How many of you have wait lists? How many of you have wait times that you're not happy with? Okay. How many of you have rapid access same day? Okay, that's actually changing. So that's pretty important. That's what stepped care is one sort of philosophy that helps us to get rapid access. So we have a lot of challenges, and the diversification challenge is important in this context because stepped care, the way we've configured it, is a very flexible model, and rapid access is typically one of the most helpful things you can do for diverse populations, because the idea of waiting to go through complex bureaucratic systems is pretty much a North American or Eurocentric kind of idea, and is not what people from non-Western cultures are used to. Some good news: the increasing media attention on mental health is actually allowing us to have more conversations, have conferences like this on innovation to get some more funding. But it's not really a crisis. The epidemiology has not changed. What's happening, there are partly because of increasing access of our institutions and human rights legislation, which requires us to set up processes that are more welcoming and accommodating of students with diverse learning styles, that we are seeing more people with difficulties coming on campus, and some of that's got to do with improvements in medications so that people that otherwise wouldn't be stable enough to attend institutions are on campus. A lot of it is because we're talking more about it, and so people are actually, it's good news. We've been saying from when I first started, we were trying to convince people that coming to the counseling center would be good for your growth and development. Well, we don't really do that anymore. We now say, please don't come here because we're too busy. So some of this is because we're doing our job, right? We're saying, come on in, and in fact, our risk-averse culture is, unfortunately, is tending to stigmatize a bit because staff and faculty and others think that we are the gods. We are the new clergy. We are going to solve all the problems, and go see a specialist if you're stressed out or anxious. And we didn't used to do that, because now everybody's worried, well, it might be a suicide. You better go see a specialist. It might be a risk. Or maybe this is the next shooter on campus. Oh, better go see the professional. And what we've inadvertently done is we've disempowered the rest of the community, students, peers helping students, or students helping students, staff who might otherwise have been quite comfortable saying, come and talk to me about that. And, why don't you, come back and let me know how things are going next week before referring. You would have lots of listening ears on campus. And we've professionalized stress management, and inadvertently we're losing opportunities to promote resilience. And so what I think we should be doing more of is helping students to fail forward, to struggle. In therapy, or in the classroom, when learning's happening, you're stressed and you're confused, or maybe not stressed, but at least you're confused, because if you're not confused in the learning process, you either knew it or you weren't paying attention. Learning is a process of entering into confusion, and so is growth and development, and so is transition. It's supposed to be hard, and I think we've inadvertently suggested to everybody that it shouldn't be hard, and you should go see a professional who will help you. And I think the more important thing, and those of you a lot of you are doing healthy campus interventions, need to keep in mind the idea is sometimes not to refer people, but to help them try, first of all, their natural community supports before they see a specialist. So the pass the hot potato is a bit of the problem, and it's a stigmatizing thing, but go see a counselor. And what I suggest to people who are teaching mental health first aid, a lot of mental health first aid is on referral processes, and that's good, but we need to really make sure that it's also really heavy on empowering natural folks on the campus to support students before they refer. Try that first. So what is Step Care 2.0? Our version is a primary care model. So like when you go to see your physician, we have people who are available for on a walk-in basis who are quite experienced and highly trained, have fairly good clinical judgment, good level of skills, and who are in a position to make judgments about, who you can risk lower intensity interventions with, and when you can risk not doing a deep, thorough assessment. So we don't do deep assessments on the first visit, and nor does your physician. Your physician does not do a psychiatric interview when somebody presents with mental health. They don't necessarily refer right away to the psychiatrist. Well, why is it that we think we have to do so much deep down assessment? Maybe it's curiosity, and that's why I went into the field. Well, I want to find out all about this person and their history and all kinds of things. But more and more it's driven by risk, the idea that we should do all that. And we're suggesting that use your clinical judgment. If something doesn't add up, maybe if there's a mystery, dig down and get the story. But first of all, assume that people are mostly well and have lots of capacities and strengths, and build on those, use a solution-focused approach. But leave the door open for follow-up. And what I often say on a first visit is, and we only do 20 to 30 minute walk-in intakes, and I say, well, we've only spent a few minutes here today, and we've got a kind of tentative plan, but chances are I've missed all kinds of things, and maybe there are things that you haven't felt comfortable talking about. Let me know if that's the case, and here's my email, and if you want to kind of have a follow-up to dig a little deeper, and there's other things that come up, or if these sort of solutions that we've come up with today, upon reflection, they don't seem to be a fit for you, come on back and we can talk about that. So the general principles of stepped care: least intensive first, and you only step up care when those either are predicted to fail or they do fail. And what I really want to encourage people to do is to model what we want students to do, which is to fail forward. It's okay to get it wrong, but be transparent about that. Say, I may get this wrong today, but let me know. We're gonna manage this risk together. So. Around suicide, it's a collaborative thing. Look, if you're suicidal thinking, if they indicate they have it, worsens, let us know. And I need to know that, and here are the options, and we all do that when we do safety plans, that's the message we send, is that you need to take some responsibility for this risk as well. So we're really talking about shifting the paradigm, and we're shifting away, I'm suggesting we shift away from a risk paradigm, because I think fear is actually one of the major themes that run through our practices, run through our campuses and our administration, and in some ways we've taken advantage of that. We get funding out of fear, we get funding out of tragedy, and tragedies will continue to, or deaths and deaths by suicide will continue to happen. I do think we can bring the rates down. They don't seem to be climbing. There's a bit of anecdotal evidence around female suicides maybe are kind of starting to creep up and get closer to the rates that male suicides are at. What we really want to do is create conditions where we have caring campuses, because that's the best suicide prevention, is to have our whole community part of the solution and not just us as the experts. So universal design, we've had some folks talk about that, healthy campus work. I really like what Brenda said from Guelph this morning around a healthy campus strategy is better than a mental health strategy. There's some risks associated with that. If we take it to a healthy campus strategy, then maybe mental health will get lost. But you know what? I think mental health is on so many people's minds right now, it's not going to get lost. We've actually achieved something pretty impressive here, that people are talking about mental health. And so let's take it a step further and destigmatize it by not isolating out mental health as something separate. It's a very, very huge part of health. Ask any family physician how many people they see that have a mental health component in their visits, and they'll say it's 30 to 50%. On campuses, I think it's even greater than that. And so we're there now with attention on mental health. Let's extend our reach by talking about how health and mental health are not indistinguishable. So for example, with Andrea's, Carter's U of T, Mississauga collaboration with athletics, Mosen from University of Windsor is trying to convince his administration to support putting him in the same building, the new building that athletics is in, because what's the single biggest natural antidepressant? It's movement, it's activity. These things are not indistinguishable. How important is sleep? Sleep is physiological. Nutrition. And so we really need to kind of embed our approaches to mental health within a bigger health strategy. So some of you may be experiencing what I say as, oh, this is risky and crazy, and maybe it is, and I have taken risks, and folks have asked me, well, what about your risk management and liability when you change the way that you're practicing? And I said, well, my legal counsel and risk management team, they work for me, so I don't work for them, so I don't get their approval. I say, this is what I'm going to do. These are the programs I'm going to try, and you're going to help me to manage that risk, as opposed to I'm going to ask you to give me permission. Because if you ask your risk managers to give you permission to try something like 7 cups of tea or some of these online programs that maybe don't have the evidence base behind them yet, they might tell you don't do it, or there's all kinds of security things that they're going to say aren't up to speed, and firewalls aren't as good as they could be. And all those things are important, but I think what's more important is what is the risk of making people wait for your services? If you can sort of take some risks now to open up access, that's probably a more a valid risk to take than one that's too cautious and says, oh, we got to wait for everybody to sign on the line to approve this. So how many of you have seen this before? Hands up. No? So this is really just shifting our focus away from a deficit model. This applies in accessibility services and counseling, and where our old models focused on requiring people to self-identify and go seek accommodations in a special office. And what we're really doing with those accommodations is we're somehow compensating or fortifying, whereas really universal design should take the pressure off folks with disabilities. Why is it that we have to give time and a half to anybody? Why isn't in our universal design of our curriculum, why don't we have the average person we set an exam so that it takes the average person half an hour, and we give everybody 3 hours? Unless your learning outcome is time-based. So there are some courses where time is actually what your speed is something a skill you're trying to develop. And so I think the same thing applies to this signing on to the Okanagan Charter and making sure that your university is an environment that promotes resilience, struggle, isn't afraid of stress, says, look, this is going to be really, really hard. And so what we're really doing is we're saying that struggle and stress is mainstream and normal and healthy in most cases and doesn't need to be pathologized, and helping people to know the difference between when it really is a pathological thing. So for administrators, this is a slide that may be of interest. And so these 3 tiers, what we think about it with the 80%, that's the 80% of the population that probably doesn't have any clearly identified health or mental health risk. They're mostly fairly well and healthy. And then we have the people that are sort of in between 15%. And then we have the 5% of people with high needs, intense needs. They're pretty ill. We spend a lot of time worrying about those 5%, and because there's a high risk to our reputation. But there's actually very little return on investment in all the resources we put into high-intensity people, versus if you put your resources into prevention programs, you're actually going to have more return on investment. And so for the counselors in the room and the administrators like me, part of the bold change that we need to make is to say, you know what? I don't want another counselor. I want, if you're going to hire some more people, I want you to do more in the blue area, because there's too many people being sent to me that shouldn't be sent to me. And I want, if the number of clinical staff that I have, they actually like working with the more intense folks. They kind of get bored working with the people that aren't, don't have as many struggles. Not always, but I mean, it's like, oh, you've come here to waste my time for me to write you a letter. Well, that's not the student wasting your time, that's the system wasting your time, because that student was told they had to come and get a letter, and that's really boring and a waste of time for you, and I can tell you it's a waste of time for the student if that's how your system works, that everybody has to come and see you for some sort of approval of an accommodation. I'm going to skip that one. Okay, so you probably can't see this. But this just gives you a graphic representation. You can see it a little better there. But I want you to look at the axis here. What we're doing with our steps, and this is part of the 2.0, a lot of this work is like I said, isn't new, so 1.0, if you will. Draper and O'Donoghue in, I think it's 2012, there's an online text on stepped care. Basically, they broke down the steps, 8 or 9 steps, similar to ours. But what we've done, one of the things that we've done is a little bit different, is what you measure is what you value. And of course, we value time. But you know what? Students value time too, and clients value time. And what we're really surprised with is as we start to experiment with session limits or session times, a lot of students say, look, I just want to come in for 15 minutes. Or I just want to come in for 30 minutes. Some students, one student who complained to me after a frustrating experience in the waiting room where, as she put it, there was no one to talk to because our counselors were busy, said, when she came and visited me, said, no, I didn't want to speak to a counselor. I just wanted somebody to talk to, anybody to talk to. And so as a result, what we've done is we've trained our reception staff to go up to the quiet room and to listen to them. We can teach anybody to listen, and quite often that's what people need when they're in distress, not always. So we're really losing an opportunity to use our whole campus more for somebody that needs somebody to talk to. And this person was actually involved with peer helping. And so I said to her, well, what about peer helpers? What if we have a peer helper program, nobody comes to see them. They keep trying to get people to come see them, no one comes to see them. Well, I said, well, why don't you hang out, take shifts, hang out in the waiting room, because I bet you there are some people that are waiting in the waiting room during our walk-in that maybe would like to go off to another room and speak with you. So that's one of the things that we measure. And then what we're looking at right now, and we're using the BHM Celeste Health System tool, which has some symptom measures. It also has a wellness scale built in, has a readiness scale and a bond scale. And what we're looking at in terms of making stepping decisions is people at the high end on this, let me just go back. People on the high end of the scale, they are, if they are really ready to work, and we're sort of reversing what might be intuitive for many of you, if they're really ready to work, we invest in them with intense services. That and so it doesn't mean that we neglect people who are severely ill who aren't ready to work. It just means that we're probably not the ones that need to help them. If they're really severely ill and at risk and not ready to work, that's what hospitals are for, to keep people safe. And now, sometimes what we do with people who are really severely ill and not ready to work is we increase the frequency of our contact, but we just spend 5 or 10 minutes with them. So we're not going to give them a 50-minute hour if they're not using therapy in any way that's benefiting them. But what often these folks need when they're not ready to work is they just need that contact. They need to come in. And so we invest our time with people that are ready to work, and then we see them regularly, but just for touch points when they're not ready to work. So readiness, we invest more resources in people that are ready. We take care of people that aren't, but we don't necessarily spend our time doing motivational interviewing for 45 minutes every week. So the other thing on this graph is that what we're really trying to do is harness when people have strengths and have some autonomy and some resilience. We want to pull those people in, identify those people first, so that we can build on those strengths by selecting an app or some kind of program that allows them just to kind of reinforce what they already know. And so on the left-hand side here, if people if you keep your programming at low intensity, chances are what you're really doing is you're building up their sense of autonomy and empowerment, as opposed to immediately sending them to a specialist, which could actually inadvertently disempower, because it's sending a message inadvertently that you need an expert when maybe you don't need an expert. This slide just shows some of the programs that we've chosen at Memorial that we've invested in, and they're not a lot of money. I mean, it depends on your budget, but when we look at it, staff costs a lot of money, and we've probably been, I would say the cost of less than one staff member, we've been able to pay for about 5 or 6 different online programs, and the commitment is less permanent, because if you try these programs and they don't work, well, you don't have to continue the license. Whereas in my university, we're faculty, and when they're tenured, you're stuck. Whereas with these programs, I'm not saying these are going to replace people, but I'm saying this gives it a whole range of tools for your staff to try out and experiment with as they try to be a little bit more flexible in their typical practice. These are just some slides that show other universities' versions of a graphic. And so the graphic idea is important. This is an opportunity for you to say, we're going to do something different. We're going to innovate, and find a way to depict your innovation in a way that's engaging and exciting. And so many folks who have implemented stepped care have thought of it as we're creating a buffet. That gives students a lot of choice about the different ways of engaging in change. And so if you're going to do something new, find a way to market it and present it in a way that's persuasive, interesting, that involves choice. And we don't turn people away ever from traditional programming. So if someone says, I don't want any of this online crap, I don't want any of these apps, I just want to talk to a person, I don't say no if they come in and see me on my walk-in. I don't necessarily say yes. I say, come back and see me next week, we'll talk more about it. And I decide that I'm going to work with someone if the relationship's good. In other words, if I'm feeling kind of interested and curious, because you know what, if I'm bored, nobody's going to find me helpful. If I'm not engaged and I'm not curious and I'm not connected to you, we know that the relationship is the biggest predictor of outcome. Second biggest predictor is the treatment context, and that's what opening up something like this can do for you. Is it opens up different options for different contexts for people to connect in the way that they are comfortable connecting and when they want to connect. So online can be 24/7, but maybe that person doesn't like online, they want to connect with you in person. Well, but maybe they need to connect with you in person now as opposed to a year from now when you've put them on the waiting list, or however long you make them wait. Or maybe if you change the way that you set up your appointments so that they're not all 50 minutes or an hour, then you're actually expanding the context in which people can encounter you. Or if you put in peer helping programs as part of your treatment model, and this is a really exciting area that we're experimenting with right now on step 9, probably couldn't read it, but what we call that is creative case management. And step 9 means health system navigation. It might mean working with your community services, developing those relationships so that the coordination is much better than it has been. but it's also about investing in the capacities of students who are severely distressed. So we are referring sometimes our highest users to things like what Cheyenne was talking about, jack.org, because activism is an intervention. And so some of our students, they might be borderline personality, they might be bipolar, they might have been in the system for a long time. The focus has been very deficit-oriented. Often they identify with these diagnoses more than anything. I am borderline, don't try and take that away from me. That's all I am, I have no identity. And I say, you know what? I believe in you more than you do. And one of the ways that we can really walk that talk is by actually hiring them. And that's what we're doing with some of our creative case management. We're using some funding to hire them to be on our client design team, to help develop, change, alter this model. And so sometimes these students who are high users are the ones that will get, anonymously, they'll get some of the complaints that come in. We've just moved into a new waiting room integrated with health. It's very busy and noisy, and so there's frustrations. And so we take that to the client design team. And what we teach the people on the client design team to do, who have always been sort of focused on what the problem that they have and that somebody else can solve it for them, they actually have a learning experience where complaints come in and they have to start being creative about coming up with a solution rather than expecting someone else to do it. And it's not an old idea. The Canadian Mental Health Association has been doing this for years and years, bringing people with client experience in to actually teach us what we need to know, empowering them to do some of this work. That's not going to work for people who are, have no capacity or so depressed that they can't actually get out of bed. But for some of the folks that are using our services that are emotionally dysregulated, many of them, no, not everyone, but many of them are actually pretty good at attending to other people's needs. And so we'll refer them to 7 Cups to be a listener. And so if you're familiar with 7 Cups, there's an online training in there that's about an hour long. It's a pretty well-developed program. But it's basically all you do is active listening. And we also provide the mental health first aid training, any of our MUN listeners that are using the 7 Cups platform. But instead of referring some of the people that are high and users of our services to go and use this program to connect with a listener so that they can talk, we're actually taking the bolder step and saying, no, you know what? I want you to go help people. And sometimes that's the best intervention, particularly for borderline personality, is to get a little bit away from the attachment issues and help them with a vocation and with a purpose. And if you think of the lack of identity that's often an issue, some of that's, of course, got attachment roots. But what is it that our institutions are all about? They're about forming often a vocational identity, a passion for life, something that we're good about, something that makes our hearts sing, which gets to flourishing, gets to positive psychology. And I think if there's one thing I want you to take away from this is, how can I change my risk approach to invest and to trust that the clients who are coming to me, who are in the most distress, actually have some capacities, and you're going to risk believing they have some capacities as opposed to spending all your time worrying about them. What better gift can you give to people who come to you than to believe in them? But that might make some of us feel worried that, am I doing due diligence if I believe in my client? So we don't have a lot of time, so I'm going to skip ahead. There's some here's an interesting book, which Beyond the Risk Paradigm in Mental Health Policy, and so. It's worth a read if you're thinking about how to deal with people that say we're not ready to take these risks. That this is something that has been thought about, particularly in social work, for some time now. That we need to really disrupt our medical model that's really not all that appropriate for wellness and psychological well-being, because. You go to your physician, and the physician makes a mistake, you might die. probably the likelihood of you dying from some kind of disease is greater with a physician, but they still take those risks. So interesting, even in the medical model, they'll take more risks with health than we take in non-medical professions around mental health. We actually are so worried of something going wrong that we're not experimenting enough. I'm going to try and skip ahead. Just close your eyes if you get dizzy with prezzies. If I had the computer here, I could scoot ahead, but we're not going to do that. So in our first session, we, like I said, we spent about 30 minutes, and what we're really doing here is using solution-focused principles. How many of you in Ontario know Karen Young? Anybody heard of Karen Young? I think she might be in Oakville. And so she's really one of Canada's experts on teaching single-session therapy. Mosh Tolman is the person you see in the picture here. I've written a couple of editions of single-session therapy. I saw an interview with him on YouTube where he was asked why did he call it single-session therapy, and he said, well, the editors made him do it because it's a bit of a misnomer. It's really open-ended therapy. Calling it single session would be like calling your visit to the physician a single session. It's not really a single session, although it is self-contained in that there's no expectation that you're going to go back for regular sessions with your physician. Most people are expecting they're going to get something out of that visit, but then they also know that they can follow up as required. So if you're not better in 5 days, come back and see me. So that's really what the solution-focused approach is about, and what you or the single session approach. And so you, at the beginning of a session, you say, well, what's one thing you're hoping to get out of today? Solution-focused interviewing, as opposed to starting with, tell me all the things that are wrong with you. So you might even want to think about changing your intake questions, like, well, what's a goal for today's session, as opposed to why did you come here? I mean, you could still have the open-ended in there, but why not try and get people to think about their goals before they've even seen you? You can do that in the waiting room. Having more assessments that are strengths-based so that when you're in the session, you can capture the moment. That's what that title's about, capturing an opportunity for learning. Capturing the moment where there's something that somebody's excited about, a client is ready to do, or maybe they've already done, that you can simply reinforce, rather than teaching them something they're not ready to learn, but you really think they should learn. Let's look for the opportunities where people are ready to work. And then a few slides, and then I'm going to open it up for questions. So that if you're not familiar with some of the literature on epidemiology, it's interesting. I don't think psychiatrists and psychologists read what epidemiologists publish, because psychiatrists and psychologists are often using anecdotal evidence to say it's getting worse. Well, yeah, it is getting, what you're seeing coming into you is getting worse. Well, that's because we've encouraged everybody to come see us, and so there's a lot of people coming to see us that never did before, and it seems like to us it's getting worse. But when you look at epidemiological research, it really isn't. So this is a study in Canada. I can't remember. I mean, some of its data takes a while to catch up. So this is, you might argue, well, things have changed since 2009, possibly. With the exception of hyperactivity, the prevalence of symptoms of mental illness in Canadian children and adolescents has remained relatively stable. Conflicting reports of escalating rates of mental illness in Canada may be explained by differing methodologies between studies, an increase in treatment-seeking behavior, or in changes in diagnostic criteria or practices. So DSM, how many do we have in there now? How many categories? 500? How many hundreds? I don't know. But it's more than it used to be. So of course we're going to have more people diagnosed if we have more diagnoses. This study suggests that some of it is to do with public awareness and self-reporting and people using terms such as anxiety and depression in a context where they don't represent disorders. So there's a lot of that going on. ACHA data. How many of you in the last year were so anxious that you couldn't really function properly? Come on, there's more than you. I mean, what does that mean? You know, I was anxious and I didn't function very well. Maybe it was for 10 minutes, I don't know, for 20 minutes. So, you know, I think these questions are important, but we're not really sure what some of this data means. Certainly from a diagnostic point of view, it's questionable whether things are getting worse. So, last slide I want to show you here is, we all know common factors research, but we keep obsessing. We obsess, whether it be on a session on apps, is it evidence-based? Does it work? Techniques are the fourth distant predictor of outcome, including apps. What's really important is you need a system of care that connects people to people, whether that be the professor, whether that be a peer, whether that be a professional, in a kind, caring way. And you need to have a context in which that's accessible. Patient variables like diagnosis, personality, third distant predictor. I mean, it's important, but it's not the biggest, most important thing. These are the things that we're all trained on, patient variables and techniques, and that we obsess about. But if we build a system that allows for trial and error and maintenance of access and relationship and shared, I mean, what is a relationship about? It's about sharing some responsibility. It's about being genuine, it's about being caring, it's about being open, it's about being receptive. So I may not get this right today, because we've only spent 20 minutes. I may have missed something, but come back and talk to me. That's what produces positive outcomes in mental health. So I'm going to stop there and open it up for any questions.
Between mouthfuls, right?
Hi.
Me first? I start with someone over there, or am I first? Okay. I basically have a question. Because you are on a university campus, how have you aligned this with sort of what senior administration cares about, like retention data, recruitment data, et cetera, and be able to sort of show those types of statistics to make them happy?
Yep. So that's a good, I was just thinking about, I was hoping somebody would ask me a question about that. So our outcome data, I mean, we're very outcome focused. Having, you know, I've given you this slide that says that what we focus on is the relationship. And so continuous progress monitoring, or as Scott Miller talks about with the ORS and SRS, feedback-informed treatment. So every session, our students in the counseling center fill out the BHM. It takes 90 seconds. They have no problem filling this out. They didn't like the OQ, it was too long. They also didn't like the OQ because clinicians weren't using the OQ in therapeutically, because it's not really designed to be used as a feedback tool in session very well. But when you use the results of the BHM in session, students love it. They love sort of seeing how things are changing for them. And then they love seeing, they love it when you talk about, oh, look at this, there's a dip in the bond scale. Let's look at those items. Oh, it says here you weren't feeling really understood by me last week. You know, what was that about? And quite often it's interesting, the clarification. I wasn't feeling understood by anybody last week. Oh, okay, so it wasn't really about the bond, but you know, just that question. One of the most important things you can do in a therapeutic encounter, and John Norcross has said this, is there's 3 questions to ask. One is, how are you? Well, we all do that, I think. How are you doing? How's the therapy going? Is this working? What we're doing, is it working? And how are we doing? How's the relationship? And if you can find a way to put that into every therapeutic encounter, given that the relationship is the biggest predictor, you're going to increase your success. And Scott Miller's data suggests you can increase your outcomes about 30% by doing continuous process monitoring. So our outcome data are always there. But more importantly, our outcome data are useful in every intervention, as opposed to just global data that I can provide to the administration.
Hi, I'm Maura. I'm from the Ryerson Counseling Center. Just have a question about groups. One of the things that we've been trying to do in our adapted step care model is to introduce some kind of first stage groups for clients to join that are open, that continuous intake type group model on a variety of different subjects. We have a buffet of different groups available. And we have really low uptake on the groups or inconsistent uptake on the groups. So just wondering if you can comment on groups generally.
Yeah, that's been a struggle. When I was first appointed at Memorial way back when in the 90s, they hired me to be the group's coordinator, and little did I know they passed me that hot potato because nobody had any success before, and I didn't have a whole lot more success. So two things with groups. First of all, we don't offer a group unless it feels like for our staff it's going to reduce their caseload. So we decide which groups to offer based on what's coming in the door. So quite often it's anxiety or depression, and so then now our most popular group is an anxiety and depression group because it covers most of what's coming in the door. So that's one thing. Secondly, we actually use a paradoxical intervention, some of us do, when we introduce group. So what do most people say, clients, when you suggest a group to them? No, they shaking head, no. Well, what would you say? Okay, I got a group for you. What would you say? Some of you might say yes. I'm not sure. Not sure. Okay, so anxiety goes up, right? Yeah, and it's not people's preference. So I say, when I see that reaction, I say, that makes a lot of sense. Group is really powerful. Especially with someone with social anxiety, I say, look, that reaction is, I understand that. You may not be ready for group, but when you are, that's the treatment of choice. And so, like hypnotherapy, which is where paradoxical interventions came out of, this is a hypnotic device too, because for some people it'll say, no, I can handle it. But you're really you're accepting that is a scary thing for people to do. There's different ways of doing groups. So George Washington's had a lot of success with offering, and a lot of people on the listserv for directors talk about, it depends the language you used. Call it a class. Don't have it in your center, but maybe in a classroom, workshop. Involve other people on campus that aren't counselors doing it, or even better yet, we have natural groups all over the place. They're called classes, right? And so we could throw out the whole model of group therapy and just take something like, have any of you heard of the wellness inventory out of California? It's worth a look. So this is a 12-week course, coincidentally, just like most of our semesters. And it's using some acceptance and commitment therapy, very positive psychology oriented. It uses the strengths wheel, the 12 dimensions of wellness, and you assess yourself at the beginning of the course, and then using ACT principles, you set goals and you let go of certain things that aren't important to you. And over the semester, there's this workbook that you use to focus on the things that are the wellness areas that are important to you. So that can be built into any faculty's curriculum. So arts and humanities, social sciences and humanities these are our leaders of tomorrow. So some programs introduce leadership courses within those faculties as part of a preparation for career. Well, in that course, you could have this wellness thing as part of your leadership development because good leaders do self-care. We pay lip service to self-care in our professional schools, but we don't really give very good tools. So why not take our group? Do we really need to do more work? Let's give it to the faculty to do by helping them find these tools that they can embed in their courses. Most professional schools, when I talk to associate deans, their biggest problem is these students aren't acting professionally. They might have 90% averages, but they actually are very unprofessional or rude or something like that, and how do I teach that to them? Well, you have answers for that. So, roundabout answer to that. It's painful, acknowledge it, and see if that gets some people participating because they want it, they're ready for that risk. In the middle? Yeah.
I want to start by thanking you so much for your presentation. I saw you on the national,
Oh,
CBC
yes.
National, and excited me the fact that you were doing this speech today. As a takeaway, we can quote that great Marshall McLuhan who said, "The medium is the message." I think the takeaway for everybody here today is that, like the ancient Chinese character, danger is crisis and opportunity. Or like the medieval alchemists who were changing lead into gold. You have looked at mental health and you said, this is a crisis, but where's the opportunity? In every crisis, there's an opportunity, and because all of your approaches are that way, yeah, they're a little bit risky, yeah, they're a little bit outside the box, but because you are looking at it that way, I guarantee you every single soul you touch at your university is going to look at whatever they're going through as an opportunity for growth, for resilience, for strength. To be a great mountain climber, you have to climb Everest and K2. There is no other way to be a great mountain
Are
climber.
you trying to make me cry?
I am trying to express my sincere gratitude for what you do and how you do it, and I'm trying to express it in perhaps a more poetic way so that everybody here today can take away from your fantastic work that if at someday it's in the near future, a few years ago I was diagnosed with adult onset epilepsy, and after a few short years of struggling with that, guess what? At some point I came to the realization that adult onset epilepsy was the greatest thing that ever happened to me, and I am the man I am today because of it. And if at some point everyone in this room can look upon these things, it's not mental, these are not diseases, these are just challenges and opportunities, and if every single person we help overcome them, they will be better for it, stronger for it, they will be advocates for mental health for the rest of their lives. Thank you so much.
Thank you. It reminds me of, and I'll stop with this, it reminds me of a story that one of the client that I saw, that's the inspiration for our creative case management approach, I've been seeing her for years with not a lot of progress, flatline sort of BHM scores. And we started a session the regular way, which is sort of complaining about everything that's wrong in her life. And then I said, I want to show you something. So we got up, I have a standing desk, we go over to the monitors, and hot off the press, it had just come in just before I saw her from our video group at Memorial. We had recorded a session that was based on her story with a student that was role-playing, a male student that was role-playing her. And so I started playing it, and I'd never seen this person so excited. She said, "That's me, that's my," she's going like this, "That's me, that's my story up there." And she was so excited that her painful experience was going into a model and was something that we were talking about at a conference, because she'd never seen her painful experience as something that could create some kind of wisdom or some kind of solution or opportunity. Great, thank you.
Thank you very much, Peter. No words that I can say to thank you will be as eloquent as those in the audience, but really thank you for changing the discourse and moving us to really much more strengths model. You've made me miss frontline clinical work, and we really appreciate it.